Kate, did you have something you wanted to say?
Yeah, I was thinking we were going to have a hilarious episode today. I think Paul's got some puns for us. Are you going to let your hair down and tell us all about what's combing through your mind right now, Paul?
I don't think coming through your mind is a phrase. I don't even think that's English, Kate.
Okay, it is the middle of the night.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cashback Memorial Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Franquato, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Hey, Paul.
Hey, Matt. How are you?
I'm good. You tell the hat story on this one again.
It's stuck with me for some reason.
Yeah. Well, Paul, we have a great guest, returning guest, our chief of dermatology at Kashlak, Dr. Helena Pasieka. But Paul, before we introduce her and before you introduce our wonderful co-host, can you tell me what is it that we do on Curbsiders?
Sure, Matt. As a reminder, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. As you mentioned, we're joined by Dr. Pasieka to talk about hair and nail stuff, but we're also joined by super producer and special co-host, Dr. Kate Grant. Dr. Grant, how are you?
I'm good, thank you, Paul and Matt. It's lovely to see you again. It's been a while.
It has, Kate. It's been such a while. Please tell us about our guest.
Okay, so we have a fantastic conversation with our guest today, Dr. Helen Pasieka, MD, MS, and she is a dual board certified internist and dermatologist specializing in complex medical and consultative dermatology. As our skin internist at Kashlak, she serves as the chief of dermatology. When she's not geeking out over morphology and distribution of lesions, she's promoting dermatology in the House of Medicine and is passionate about medical education and multidisciplinary teamwork. And today on this episode, Dr. Pasieka is going to teach us a framework to assess general and patchy hair loss, which can be temporary or permanent. She's going to look at the current tests and treatments, and we're going to touch on psychosocial factors affecting the self-image of patients whose hair is coming out unintentionally. We also are going to quickly touch on assessing pigmented and pitted nails. So without further ado, let's get to it.
And a reminder that this and most episodes are available for CME credit for all health professionals through VCU Health at curbsiders.vcuhealth.org. Helena, welcome back. It's been a little while. We're so excited to have you back to talk some hair and nails. But first, remind the audience, what is a current hobby or interest that you are into?
Oh, it's so good to be back. It's nice to see everybody. Thanks for having me. A current hobby or interest, I have really become a ski bum. So we have taken to skiing locally. It's East Coast skiing, so it's icy, and the song you start with at the top is the song you end with at the bottom, sadly. So it's nothing like West Coast skiing, but our family gets out there and we have a lot of fun.
Yeah. Probably wear helmets on the East Coast slopes with all the ice and everything, but
helmets everywhere. West Coast, yeah. East Coast.
When I was a kid, there was no helmets on. It was like maybe you'd see them like very towards the end. But when I was a kid, no one was wearing helmets for anything. Paul?
Yeah, we had no helmets.
No, not a whole lot of skiing where I go, but a lot of bicycling with certainly sans helmets and just a lot of trip to the ER, which did not actually change any behaviors at all, weirdly, now that I think about it. So it's better times now.
Okay.
I also didn't grow up skiing. So, I didn't even put on a pair of skis till I think I was 20. So it's been an adult hobby, and I encourage everyone to develop an adult hobby.
Yeah, skiing's good. All right. Well, we have a lot to talk about tonight. Joining us from the middle of the night in England is everyone's favorite, Dr. Kate Grant. Kate, can you start us off? We're going to get to a case from Kashlak, but if there's anything you wanted to say about hair ahead of time to set this up, now's your time.
Okay. Well, I've still got mine, and I think you guys have as well. But yeah, I'm joining you from the middle of the night in Cornwall at the moment. So I'm on the west coast of the country. I've just been up to a walk on the cliff looking over towards the Atlantic last night, and Yeah, just have a great time here. I'm in a little mobile home at the moment. I'm working away from home, doing a GP locum. So I just
Kate will
driving
someday
across
write
the
a book.
country. I know.
Yeah,
Travels with Kate.
yeah, Kate, you have a very interesting life. So we have a bunch of cases we're going to go through on hair and nails. So where do you want to start?
So, as you know, it's my great delight to be the um, chief of dermatology at Cashlack Memorial. But for any of you guys who know that I have a side gig in my real life, I just wanted to let you know the mandatory disclaimer that I do not represent the federal government. The opinions that I express here in this podcast are my own and in no way reflect the U.S. Department of Defense. So, thank you.
Right then, so we have case number one is Kerry. She is a 19-year-old student who arrives at the primary care clinic at Cashlack Memorial. She tells you her long hair is falling out in handfuls. She gets hairbrush hair. It's coming out on her pillow. Her shower gets clogged, and her ponytail band is about half the thickness that it used to be. But her last doctor said, well, it looked okay to them. So she suggested that Kerry could try some multivitamin. So that wasn't evidence-based. That was just sort of just general, anecdotal evidence. Anyway, Kerry spent a lot of money on shampoos that promise a lot. Nothing is helping. And it's been about 3 months without improvement. She's now getting really distressed, feels her concerns were dismissed by her doctor. She thinks she needs blood tests. She's Caucasian. She's on a weight restriction diet because she's a flyer for her cheerleading team. And she takes a multivitamin supplement, which she read was good for hair and nails because it's got biotin in it. She takes no regular medication except the combined contraceptive pill. She's not pregnant, and she has a family history of psoriasis. So there's a lot in there, Helena, but it's a fairly standard late teens girl coming to you with a mixture of sort of like anecdotal stuff as well as personal history. So can you take us through your standard hair and scalp assessment for a young lady like this?
Sure. And this is actually a pretty typical case that we would get in the general dermatology clinic or in the primary care clinic. I think we've all seen patients like this. And so, just even from the door, or even as they're being roomed, sometimes you can take a look and get a sense of someone's affect, how troubled they are. Um, hair patients, it can be very emotional. And so sometimes they're quite anxious or quite down about their hair. But even as I'm entering the room, I always tell my residents from the door, I'm looking at their frontal hairline, their eyebrows, their eyelashes. If it's a gentleman, I'm looking at their beard area, mustache, sideburns, looking for any areas of sort of patchy alopecia or areas of hair loss. Hair culturally can be quite sensitive. So when I'm doing an examination of the scalp and hair, I actually almost always start with the hands and nails. An examination of the nails is a standard part of your hair exam. And just at least in Western culture, greeting somebody with a handshake or at least introducing yourself by touching the hands is very sort of culturally normal. And it can really be off putting to people if you go straight for their scalp or straight for their face. And so I really do sort of shake their hand and then take a look at their nails. And really, what you're looking for is pitting or ridging in the nails. And then you kind of chat with them a little bit about their chief complaint, what they're there for. And then I always ask for permission. Can I take a look at your scalp? Is that okay with you? If women have their hair up, you mentioned that her ponytail girth has gotten smaller. And I love that you asked that question or put that in the question stem, because I think we've talked about that in another Curbsiders episode. But really, that ability to twist your hairband one more time or two more times as compared to your baseline can really be a great screening test for thinning of the hair. Asking them to take their hair down so you can examine it, or for people who have hair pieces in or locks or braids, asking them what's the best way for me to get a look at your scalp, and having the patient sort of partner with you in that so that you're not sort of like just, you know, I'm a really bad hairdresser. So you don't want to get in there and sort of rough everything up. And you do want to sort of ask for not necessarily consent, but permission.
Yeah, and I had somebody with the exact same problem even last week, and I was thinking about this, and I needed to be really careful about not disrupting how she was going to look at her, like when she walked back out to the office, because she'd tried to cover that big patch so carefully that you just have to think about how they're going to walk back out the door again as well, don't you?
Exactly. It helps to have a little handheld mirror a very inexpensive one is a good thing to have around, just so patients can kind of get themselves back together before they leave the office. That can be really a thoughtful touch, and it can cost you not much, a buck or two.
Paul, I'm sure you're loving the physical exam talk. Are we anything else you want to ask about here?
Not in the exam so much. Actually, I wanted to ask a little bit more about the history, which I presume we were doing before we get to the physical examination. Actually, I think we got a lot of good history here, just volunteered by the patients. So, where the patients find the hair and sort of the change in the ponytail girth. Are there any other sort of historical things? Because I never quite know where to go from here. Like, is it seem like a lot of hair? Is that a helpful question, or sort of? And maybe I'll ask about sort of tight ponytails or chemicals and stuff. But then I feel like I kind of peter out and give up. But like I think a lot of probably primary care doctors do. So, what's your history look like?
Yeah, perfect. So, I have this way of teaching this that I call, "Is it this or that?" Right? And so, is it really that the hair is falling out from the root, or is there's fragility and breakage? Is the hair not growing as long as it used to grow before because it's, brittle, or it's been heat treated or chemically treated, or is it truly that it's, coming out, from the roots? Because there's lots of reasons to have hair on the pillow or hair in the shower drain, for example. Patients' perception of how much hair they're losing, whether that be a lot or a little, can be off from what we expect from biology. We expect people to lose several hundred hairs every day. So I don't find that having people do hair counts or bring in bags of hair tends to be
Oh my
very
gosh.
helpful. And I actually discourage that because some patients kind of get fixated on that. I think meeting patients where they are, if they feel like they've got hair thinning, asking them if they feel like it's diffuse or, if it's in one location or another, hairstyling practices, especially, I think most of us don't necessarily get the most education on cultural styling practices, especially for ethnic and textured and kinky and coily hair types. And so learning a little bit about that can be helpful. Asking if they're heat treating or using chemicals on their hair, I think can be helpful. But it's really easy to get into the weeds and sort of then get information that you're not sure what to do with. And I find that that makes it kind of challenging from a therapeutic relationship. So I think the things that really, especially internists, can focus on is I heard a lot about Kate, right? So she's 19 years old. She's a cheerleading flyer. She's on a weight restricted diet because she needs to be able to like fly high at her games, right? And so, getting a sense of, how weight restricted is she? Is she doing, intensive dieting? Is she restricting various nutrients or certain types of food? I think would be helpful. Has she had any recent changes in her oral contraceptive? I think you said she's on a pill, but certainly people who switch from a pill to, a long-acting contraceptive that's progesterone only, that can cause some hormonal shifts and changes in hair for sure. Was she recently pregnant? Was she recently ill? Did she have a major life stressor? And so all those things I think are very pertinent and a very comfortable history for internists to take. And so those are probably the places I would focus with Kate right now.
What are you thinking on the differential for just a young person, like young woman coming in with concerns of hair loss?
Yeah, so she mentioned a family history of psoriasis, and certainly when you have psoriatic involvement of your scalp, it can cause, sparse hair growth for sure. Hair does not like to grow in the setting of inflammation, and we'll talk about that, I think, a little later in some of the other cases. But you'll get to the bottom of that with your exam. Nutritional restriction, hormone shifts, life stressors. I mean, that all is sort of pointing towards telogen effluvium or, a nutritional etiology for her hair loss from her restricted diet. She didn't mention if she has a family history of thyroid disorders, but certainly I think screening for a thyroid disorder in a young person with impressive hair loss is a reasonable thing to do. She's young and she's menstruating.
Yeah, and she came in asking if she needs blood test, which is a quite a
Yeah,
common thing they ask as well. Are there things that you particularly pick to screen if they're pressing for that?
I keep it pretty simple. And I think the practice across various dermatology practices vary a little bit. But from a cost and yield standpoint, I think simple things like a CBC, just to look for anemia and ferritin, iron deficiency is a good place to start. Most of us are checking a vitamin D. Just because vitamin D deficiency is pretty ubiquitous and vitamin D is pretty important in hair biology. And maybe a TSH, kind of depends on the rest of her review of systems. I lean away from an ANA because a telogen effluvium type picture as the primary presenting um, symptom of lupus would be pretty rare in the absence of other symptoms,
Yeah.
and you're so likely to get a false positive or a 1 to 40 or a 1 to 80, and then the patient's worried like, oh, I have lupus and that's why my hair is falling out. I think it gets pretty muddy pretty quickly, so I put that one in my back pocket and I follow the patient. Obviously, it's not a one and done, and if they develop symptoms later on that have you concerned for lupus, certainly you could add that later, but it's not part of my screening by any stretch.
Can I ask about, and you may not be able to answer this, and this may not be a fair question to ask, about the micronutrient deficiency or the thyroid dysfunction? I feel like so often I will go hunting for that in terms of this,
Mhm.
and maybe I'll find something a little bit off. And after
Mhm.
correction, I'm not sure I've ever seen the hair get sort of markedly better as a result. I guess, how substantial impact do you see that play? Like if you replete someone's vitamin D or they're hypothyroid and that gets corrected, like how dramatic improvements do you see with that, or is it sort of a case by case basis?
I think it can definitely get better. The one thing to remember is that hair is really slow. You need 16 weeks of whatever's working to even see the beginnings of the wispy kind of baby hairs growing. And so I think if patients are looking or if physicians are looking for a really quick fix to know that they did the right thing, it's just a very unrewarding exercise in that way. So I
Yeah.
tell people to mark their calendar, like literally circle the date 16 weeks from today if we're repleting your vitamin D or if you're ferritin, we get ferritin sometimes that are like 10 and 15. And that's pretty profoundly low. If you talk to hair experts in dermatology, they really like to see that ferritin closer to 50, which might be an overcorrection, but of course it's a hair expert and that's what they do. So, really boosting that ferritin with iron supplementation. And then again, once it's, improved, it's 16 weeks from then that you're really going to see an improvement. So, same thing with thyroid supplementation, and hair just takes a long time. There's nothing fast about it.
That's terrific context. Thank you.
Our iron guy recently told us, I think he said 100, Paul,
Yeah.
right?
Yep.
He said 100. He said he's like, so, there's some evidence we had on Tom DeLory, and he was talking about ferritin levels of 100, which is like really high, because usually 30 to 50 we're like, okay, they're fine. But
We get it.
so yeah, maybe pushing it high. I love this. So this patient, let's say, we don't see any patchy hair loss and we don't find any micronutrient deficiencies. Ferritin's okay, TSH, vitamin D is okay. She's in the sun a bunch. So are we ready to call this telogen effluvium? And if so, what's your spiel like? Like, how do you counsel patients through that?
Yeah, so are you saying that she looks like slide 8?
Sure. Let me see if I can pull this up here.
So I could just talk a little bit through the exam. So you can see she's got those wispy kind of baby hairs at the frontal and temporal hairline. As you look back towards where she's got her ponytail, you can visualize her scalp. What's important about this picture that I just pulled from the internet actually is that this is not your midline scalp, and you would not call this widening of the part, which we'll talk about later. This is really just a lot of sparse, kind of thin hair throughout. And so you can see here her beautiful eyelashes, her eyebrows are intact. She looks maybe a little sad. She wants her hair back. So that would be the extent of the exam. And I think you asked me, for telogen effluvium, what's the approach to treating that? So I think for her, she probably has an element of sort of a hypocaloric state, which of course makes it really hard. Your body's really smart and hair is really metabolically active. And so when you are in a hypocaloric state, your body says, you know what, the thing I really don't need to do right now is grow like a bunch of extra hair. So it stops, if you will. And that's kind of how I describe it to patients. And so for her, I think getting her calories up, making sure she's getting enough protein is really important. I don't think I would necessarily go changing her oral contraceptive agent, assuming it's not a progesterone only pill, and just making sure that she's mitigating her stress. I joke that for these patients, I prescribe a stress-free life, which I know can sound very dismissive, but you really do, when you're coming out of a telogen effluvium, need to take really good care of yourself. So that means a healthy diet, good sleep, whatever soothes you and mitigates your stress is really important. And for the vast majority of patients, this is all going to come back. It's completely reversible, and your hair will be what it was before the incident. And why does telogen effluvium happen, right? Patients say to me, well, what the heck? Why did it happen? We are mammals, but we do not molt. Okay. Many mammals molt. So they go through a cycle where their hair, sheds all at once, seasonally or in response to UV radiation. But we don't do that. So we are constantly cycling between telogen and anagen growth of hairs, and a certain number of hairs is supposed to come out every day. And in response to either metabolic or physiologic or psychological stress, childbirth, surgery, you name it, sometimes your hair, instead of cycling like this with that average number falling out, your body says, you know what, forget it. I'm just going to conserve this metabolic energy. And so that's what happens. And when it starts to grow back, it has that kind of wispy look frequently. And that's how you know you're on the right track. But don't look for that before 16 weeks because it's a waste of time. And don't let people quit before 16 weeks because that's a waste of time too. Oftentimes patients will say, well, I tried this or I tried that. This patient's doing a ton of very expensive things, right? They're taking supplements. I'm presuming if it says hair and nails on it, it's probably got biotin in it. But unless she is truly biotin deficient, that's actually probably not going to help her. And some of these supplements are incredibly expensive. And so I do empower people to stop taking those. They do have some side effects, biotin in particular. I think you guys have covered it on the show. They can falsely depress your troponin levels. They can interfere with thyroid assays as well. And they can even interfere with BNP. So for patients who are older and might be having cardiac problems, it can become really problematic. And there's no great evidence that it helps to grow hair or nails. So we do minimize those. Shampoos also don't do much. If you love your shampoo and it feels like self-care, definitely continue. If it's breaking the bank and you're not seeing much change, certainly I think that's another area you can switch to doing something less expensive and still get those really good results. Some patients are very motivated. And so I think doing something like a topical minoxidil is a reasonable place to start. I think we've talked about this on the show before, and we could probably recall those notes or point in that direction, but I recommend 5% for men for everybody. So sometimes there's a 2% or a 3% for women. I recommend 5% for everyone. It's either a lotion or a foam or a solution. Use whatever feels good and works with your hair texture and type. And again, don't expect to see much change before that 16-week mark. You have to use it pretty consistently.
Beautiful. All right.
Do you also get that slight increase in hair loss at the beginning of using minoxidil?
I'm so glad you asked about that. That freaks a lot of patients out, but that usually indicates that you are a responder because the minoxidil is thought to be putting your hair back in cycle. So you can kind of get that paradoxical, telogen loss of hairs. And then in patients who are going to respond to the minoxidil, you usually have that, hair growth that shows up in the next 12 to 16 weeks after that. So it's good to counsel patients. You might see a little more loss when you first start, but push through that. And if it's not made any difference between 16 and 20 weeks, we can stop.
And do you guys have this concept called like the doctor as the drug? Do you ever find that sometimes when you've just like within like the first few minutes, you just think, right, this is telogen effluvium, and then you saying to the patient, actually, I can see all your baby hairs. I can reassure you this is all going to come back. And they kind of need you to hear that. They need to hear it themselves that you actually, aren't worried about it. And that can just reassure them that they don't need to be doing anything more than just giving it the time it's going to take.
Yeah, I think I do the physical exam quite out loud for a couple of reasons. One, I usually have trainees with me and they need to learn how to do the exam. But two, I think it's really important that the patient hears you describing what you're seeing. They really feel like you looked at them. They feel like you appreciated the changes there. And I'll even say like the negative findings out loud. Like, I do not see any evidence of psoriasis here. there's an absence of scale on your scalp. Your scalp looks healthy and normal. That's really good. And I think that, there's a lot online, there's a lot on TikTok and Instagram, and it can get really confusing for patients, oh, maybe it's not growing because I have scalp inflammation, or maybe it's not growing because I used a shampoo with sodium lauryl sulfate and I need to go, SLS free. And I think it's really nice to sort of meet people where they are at the end of the visit and try to figure out, like, what are you doing? And let's talk about the things that are really going to help you to move forward. And I think patients really do appreciate that.
So I wanted to ask about the minoxidil treatment specifically for telogen or telogen effluvium. What is the duration of treatment for that? Because if this is by definition or by nature a transient thing, and we're just trying to sort of kickstart them back into the right cycles, like because my understanding is like once you stop using it, it no longer becomes effective. In this case, that seems to be less of an issue once you kind of get things going. But how long do you counsel treat patients to actually use minoxidil for telogen effluvium
For
specifically?
telogen effluvium, I give them the option to do it if they are highly motivated and anxious about it. I am not convinced that it changes sort of where patients end up at the end.
Yeah,
I counsel that it's certainly not going to hurt them. It has some evidence. It certainly promotes hair growth, and it might get them to the end point maybe slightly faster. Does it grow necessarily more hair than you would have recovered? Definitely not. And you're exactly right. So, unlike androgeneic alopecia, which is, kind of female pattern, balding or male pattern baldness, where when you stop the minoxidil, you would expect to see a loss of all that promoted hair. In this condition, if it's truly telogen effluvium, there's no harm in stopping it. So, if they're motivated to try to
right.
kickstart things, they want to do something and spend their money on something that has some evidence, I think I'd far rather have them do that than, spend money on some of the branded, quite expensive biotin containing, vitamin supplements, all these fancy shampoos and things, which I think don't tend to help.
Let's go to the next case. And Kate, do you want to read it?
So, um, Kerry is now 10 years older. You're going to get to about 100 years old in this. So, 10 years older, she comes in and she says, I have hair thinning and an itchy scalp. You notice some dandruff on her collar, some red, dry, flaky skin around the eyebrows and nasolabial folds. She's got painted nails. And she tells you that they look so thickened and gross without a manicure that she keeps getting her nails done. Her dad has got psoriasis, which she mentioned the last time she saw you. He told her it was psoriasis on her scalp and her face, but she's not so sure. So can you now adapt the history to like an itchy, flaky scalp assessment for us?
Yeah, for sure. The distribution you described, the itchy, flaky scalp with the eyebrows, nasolabial folds. If this were a gentleman patient, sometimes that little mental crease will become involved, sometimes central chest, both in men and women. Certainly sounds like seborrheic dermatitis to me. Quite common. Other places you can look are in the conchal bowls and in the external ear canal or in the postauricular crease for sure. And you'll find that sort of waxy scale with erythema can be quite itchy, actually. Patients will often describe that they have dandruff, but it's not terribly specific because psoriatic scale can also look very snowy and dandruffy. And so I think sort of teasing that apart, she's got a family history of psoriasis. So then psoriasis also shows up on the differential here as well. Scalp psoriasis can be the only presentation of psoriasis. You may not have psoriatic plaques on other parts of the body, but certainly this is a patient in whom you're going to think about doing a little more of a comprehensive dermatologic exam to look for those classic kind of typical hotspots that we know psoriasis likes to involve: elbows, knees, umbilicus, sacrum, gluteal cleft, postauricular spaces, nape of the neck. And so you can take a quick peek there for sure. And then the nail changes. So, seborrheic dermatitis does not tend to have a lot of nail changes. In fact, I would say there's an absence of nail changes. There are innumerable reasons that she might have nail dystrophy. And of course, it will be hard to really assess that if she's wearing acrylic nails or nail prosthetics or gels that are very thick. And so, maybe assessing that after she has her nails removed might be in her future. But repeated manicuring, manipulation, psoriasis has nail changes, onychomycosis has nail changes. I've had patients who have unfortunately contracted subungual verruca, so warts that they've been introduced by the manicure salon or home manicuring where they've dragged the wart virus up and under their nails or in the
Gross.
perineum. Yeah, it's really unfortunate for them. It's a bummer. And that can cause a lot of nail hyperkeratosis, nail lifting. And so really getting a good look there, and not necessarily putting everything into one bucket. Like we love Occam's razor, but you really do need to take a peek there, and try to figure that out.
Okay. Do we have any pictures that we want to show for this one?
Yeah. So I would ask, I guess, does she look more like 11, slide 11? Yeah, so here you see, definitely some scale, adherent to the scalp. It's a little bit yellowy, possibly slightly waxy, pretty fine, diffuse throughout the scalp. Not a ton of scalp erythema here, but sometimes you'll see some pinkness of the scalp as well. And that would be in contrast to, say, slide number 12, which you can see is what we classically call kind of micaceous scale or mica-like scale. Mica's, that rock that makes baby powder. And one of the things that's sort of interesting about psoriasis is that it doesn't respect the hairline as a boundary necessarily. It can, but frequently in scalp psoriasis, you'll see it come down maybe a centimeter or two beyond that frontal hairline, post-auricularly, and then extend down onto the nape of the neck there. This scale is very, very dry, and it would demonstrate what dermatologists like to call Auschwitz sign. So if you tried to pick up a little bit of that scale, you actually might even have a little bit of pinpoint bleeding under there, whereas the seborrheic dermatitis scale that we showed previously just kind of sloughs off.
And then just a history note there, Helena. We were talking about the acrylic nails. There is some case reports now and just some useful information about allergy to acrylic nails and the method of applying it. A lot of people are using home kits to do it themselves. Can you tell us a little bit more about people who had adverse reactions to nails and things?
Yeah, people really love their nail prosthetics. They're trendy and they're fun and they're, easy to change, and they're like a little bit of self-care, right? So people love them. Depending on the type, there's like acrylics and prosthetics and gels and wraps and like there's an endless amount. One of the things that can happen with repeated exposure is sensitization, a proper allergic sensitization of the skin, generally to things like acrylates in the nails, which is like one of the hardening agents that makes it like firm and shiny, but also to some of the chemicals in even just nail polish or some of the gels. So certainly, I think sometimes when there's chronic paronychia or itching or thickening, considering something like allergic contact dermatitis is really important. And it's really hard to get people to break up with their nails because people tend to like them, but giving it, a good prolonged period of abstention to see if things get better is really helpful. And then the other health risk that we've noticed with some of the nail treatments is really just the repeated UV exposure for some of the nails that are hardened with little UV lights. And so there's been a little bit of a shift in the industry to using LED lights of a certain wavelength to harden them that aren't UV, but certainly repeated exposure under those UV lights to harden the nail polish gels or to firm up the acrylics, we think is a risk factor for the development of squamous cell carcinoma in the periungual area or of the nails. And so certainly we have to keep that in mind as one of the risk factors and something we certainly wouldn't want to miss.
And we sometimes see people who come in having scratched their face, and everywhere that they're touching with their nails, they get it on the backs of their elbows, they get it around their eyes, and then you think that they've actually got a different skin condition altogether because it's widespread in multiple places, but actually it's because of everywhere they're touching and scratching.
Yeah, the number one thing we see is eyelid dermatitis, actually. Eyelid dermatitis is often the first presenting sign of an acrylate or a nail product allergy, for sure.
Paul, I'm learning something here. This is all unfamiliar territory.
I should probably be asking more questions for sure.
Yeah.
I had a patient picking her nails off, like all 20 of them during a consultation because I was just saying that it's your nails, and she's just picking them off like she had the plague. It was awful. Yeah, she left them on the desk.
Oh dear.
So, Helena, we had a question about, determining, we're talking about thickened nails, we're talking about the scalp and flaking. How do you like to differentiate, like when do you suspect fungal cause, and how do you like to sort that out?
The quick and dirty answer is that adults really don't get tinea capitis very often. So hooray.
That's good.
We see it a lot in children. We do not know why people tend to develop, an immune tolerance to this in adulthood. When we see tinea capitis in adults, it is generally pretty impressive. It is patchy. There's areas of alopecia. You'll get that cervical lymphadenopathy just like we see in kids. So often it's that occipital or sort of cervical chain lymphadenopathy. It tends to be pretty uh, inflammatory in adults, I would say. So it's often like quite inflamed, a little bit moist. And so in those cases, sending a culture from the scalp or even plucking hairs and sending the hairs to the micro lab can be really helpful. But I think I've probably seen in the last 10 to 15 years fewer than 10 cases of adults with a proper tinea capitis. So it's just not something that comes up on the differential very often in adults. You can certainly have fungal infections of your nails. Hands are far more rare than toenails, where onychomycosis is quite common. And there, I think doing a nail clipping can be helpful. There are also some mimics, though, like 20 nail dystrophy, which is actually a benign onychodystrophy that can occur in the hands and the feet. And I think doing a clipping and having a negative result there can be helpful. But in those cases, I think you'd be sending to a dermatologist or to somebody who could help with that. That's a pretty rare entity.
Okay. So let's talk treatment for Carrie. So I guess the initial diagnosis you said was probably seborrheic dermatitis, but what if it was psoriasis? Can you talk about both scenarios? What you would be giving?
Yeah, so I think we decided based on the distribution of her involvement, the fact that it included the sort of medial eyebrow area and the nasolabial folds. Those are very atypical locations for psoriasis, more common for seborrheic dermatitis. And depending on her hair type and how often she shampoos her hair, if she's like a white person like me and she's able to shampoo frequently, then I think using a medicated shampoo lathered to the scalp, not necessarily the hair, and then also used as a face wash. You can use that medicated shampoo as a
Mhm.
face wash as well. In somebody who can tolerate daily hair washing and doesn't have a dry hair type, you can really kickstart things and get them looking better within a week or two, just with daily use of a medicated shampoo. That would be totally inappropriate advice for somebody with a drier, ethnic, coily, kinky, hair type. A lot of folks with textured hair types or curly hair types, their hair is quite dry. And so recommending that someone with that hair type wash their hair every day is just really inappropriate advice. Their hair would become so dry and itchy and it would break. And so it's really, not going to work for them. And so in those situations, it's not inappropriate to recommend the shampoo, but just know that they're not going to be able to use it very often.
Mhm.
So in those situations, you can use a little bit of a very mild topical steroid like a fluocinolone, for example. Some of these things even come in like a very specific scalp preparation with like an application nozzle. And that can really decrease some of the inflammation that we see with the seborrheic dermatitis and keep that scaling and flaking at bay. Another thing that I'll mention, just because it's kind of trendy right now to use SLS free shampoos, right? Everyone's trying to have healthy hair, and these lathering agents are considered quite drying. So that's sodium lauryl sulfate. I find that the patients who are using some of these, paraben-free, SLS-free, all of like the very natural free and clear, they're more prone to seborrheic dermatitis. And I think it's because they're not removing that pityrosporum yeast that's sort of ubiquitous in the environment. They're not getting it up and off their scalp with that lathering action. So if they're having repeated bouts of this, maybe switching to a shampoo that has the SLS in it, even though it's not a medicated entity, can really help them to keep this from coming back. It tends to require some degree of chronic maintenance of some kind, because if you're prone to making this, it's probably going to come back. But having somebody kickstart it with daily use, if that's appropriate, and then having them use it even just once or twice a week to keep things at bay, the ketoconazole shampoo or the cycloperox shampoo in prescription strength, I think is a good place to start. And then
Mhm.
allowing it to use that as a face wash is a great trick too.
And do you have to dilute it as a face wash, or do you just use it neat? What do you recommend?
Straight up, no chaser.
Okay. Okay.
And for psoriasis, my patients with psoriasis are seeing a dermatologist. That it just seems like a higher risk condition. So if we think someone has scalp psoriasis, should we be sending them to you?
I think it's completely reasonable to give them a topical steroid, like a clobetasol, a very high potency topical steroid solution. It comes in foams, it comes in solutions, it comes in, you know, oils even. Pick the vehicle that the patient would like to use. Most patients know what they like to use on their scalp and hair. Remember to counsel them it's not a hair treatment. So if you're glopping your hair with a clobetasol solution, that's not the goal. You really want to get it on the scalp only and
I
really
got it.
massage it in. It's a scalp treatment, not a hair
Okay.
treatment for all of these things. And then sending them forward to dermatology is appropriate. Terrible scalp psoriasis is an indication to use a biologic medication for psoriasis. And so that would be a conversation that we would have in the dermatology clinic.
Okay. Let's move on to case number 3. And Kate, if you would read this one. I guess
Sure.
we're getting older and older as this goes on.
Yeah, we certainly are. So, patient now is Kerry's mom, because she thought you were amazing with herself. So her mum's comes to you for help because her hair is thinning. So she says that her hairline's receded. She can see her scalp because her part's getting wider. She's distressed about looking like a man, and she says what can be done to make it grow back. She wants you to do blood tests for her hormones, and you notice that she has got quite a withdrawn affect. She is tearful. She says she's got poor self-esteem, lost her confidence. She doesn't like going to social events anymore. She works from home, which is increasing her sense of isolation and rejection. And she thinks people stare at her when she's out and about. So Kate has talked to us about the older person who's now losing their hair and they think they're going to go bald.
And I can bring up the slide for this as well.
Yeah, so we sort of brushed up against this when we were talking earlier about telogen effluvium, right? About how that was more of a global thinning, whereas for a lot of women, like Carrie's mom, it's really that widening of the central part. And so here in this picture, you can see on the left-hand side is a very sort of narrow, tight band of visible scalp there. And then there's varying degrees of what we would call androgeneic pattern, androgeneic alopecia. And most women will describe that they can just see more of their scalp, that their part has widened. And the reason that happens is because of miniaturization of the individual hair follicles. There's also a change in the sebaceous glands in androgeneic alopecia. And so not only is the scalp more visible, but it's also shinier. And so, it's more prominent, it's shinier, it feels more apparent to the world around them. And of course, this can run in families. It can happen quite young. It can happen even as early as the late teens, but for most people, it happens around perimenopause. And I think it can be associated with a lot of, sort of negative feelings about people's appearance and aging and senescence and loss of their youth. And so it's not surprising that patients often don't feel their best when this is happening to them. Um, Suffice to say, and I do tell all my patients, hopefully without dismissing their concerns, that none of us are going to have the hair at 80 or 60 or 50 or 45 that we had in our 20s. Every single person, as part of a natural aging process, is going to have, less hair, thinner hair, and that's just the reality of the thing. And so there's a part of this that is normal and to be accepted, and then there's a part of this that can really be, you know, outside of that norm and very distressing to folks. I think for her, talking a little bit about what she's tried already would be a good place to start. There are all kinds of things that people do, including wearing caps and scarves and pieces. There are some camouflages that you can use. I'm not going to use brand names, but there are like powders that are you can like puff into the hair to sort of dye the scalp, the color of your hair and make it less apparent. And sort of figuring out, how much time and effort she spent trying to camouflage this and then really digging deep about, it sounds like she's quite depressed actually. And so figuring out, how much it's keeping her from doing her activities that she really loves, and then going from there with regards to treatment.
I may have told the story even to you, Helena, I think before, but I went to see a dermatologist for something completely unrelated, but they were nice enough to do an entire skin exam. And she said at the end of it, and she's wonderful, by the way. So this is all ending in a compliment to you in terms of being thoughtful about language. But this dermatologist is like, and also I think you might want to consider incorporating a hat into your outfits. And I was just like, haha, that is a nice way to say that my center part is widening and I should use a little bit more sun
No.
protection. So it was, and it was not. It was. And I'm not making fun of her. It really was. The way she said it sounded very natural, but I appreciated like that. There are so many ways that you could have said that would have actually probably hurt my feelings, and I think that was maybe the funniest and sort of least offensive way. So this is all my long-winded way of asking, sort of
You know,
what phrases do you use, or how do you talk about this? Yeah.
you know what I love about this the most is that to my dermatologist ear, you know, I think she was trying to tell you to be proactive about photo protection and the degree of UV radiation that, because I don't know if you've noticed, sir, but you don't have like an excess of melanin. And so I suspect you
Maybe even a
are,
deficiency.
yeah. And so, in our counseling about daily practice and photo protection and skin cancer risk and so on and so forth, I think I would probably say something like that as a part of like, get a hat, there's a spiel there where I'm like, get a hat that you feel cute in, that fits
Sure.
you well, that's not too hot, that like you feel super fly in, because if you don't feel good in it, you're not going to wear it. But that has nothing to do with someone's central widened part. So this is why specialties need to talk to each other. Because I just learned a lot. Like, I wonder how many of my patients have wondered, like, is she saying I'm going bald or thin?
I think this may have been in the context of discussion about my hair specifically, but it was years ago at this point now. But yes, no, I fully appreciate that point.
Well,
So
then, yes, if you were
And I guess
talking
the
about
back to
hair
the
loss,
original
then
question is there, in terms of how you have these conversations about hair, are there phrases that you avoid or ways that you discuss it that are not triggering or perhaps alarming to patients that still get your point across?
I think the idea that you're going bald is very scary for some people, because their hair is thinner, their scalp is more prominent. They don't know if this is going to progress to the end till there's like nothing left up there, um, or what's going to happen. And I think using the word bald, if the patient uses it, then I'll use it. But I don't say, hey, you look like you're going bald up here, or I see the central balding, right? Like that's a
Yeah,
little bit
right.
rough. I talk about hair thinning. I talk about, again, like a loss of fullness. But I
It's a
certainly
good
don't say
word.
like you're balding.
Helena, I wanted to ask about, because I get asked this question a lot. Can you check my hormones? I feel like that's why my hair is like so for a woman, whether they have the pattern where they're going like temporally, they're receding,
Mhm,
kind of like like a man typically would, or if they
mhm.
have sort of the widening the part, the thinning of the hair on the top of the head. Are you doing any sort of like hormone testing, and then this will lead into treatment as well when we talk about that?
Yeah. I try hard not to, unless I'm, treating in conjunction with someone who is doing like hormone replacement therapy, or they have an
Mm,
endocrinologist already and they're concerned about, pituitary hormones, growth hormones, a menopause expert, for example, if someone's going into early menopause and they're doing an investigation for early ovarian failure. I mean, I think those are like actionable things that I would partner with those folks anyway. But for your standard patient who comes in perimenopause and feels like they're having some androgenetic alopecia, there's plenty we can do. Um, and there's not much to correct about menopause,
mm,
I don't mean to dismiss it. That sounds wrong. But what I'm trying to say is, checking hormones outside of, thyroid hormone, like we talked about earlier, there's not going to be a lot that we would deploy, right? So
mhm.
I tend, at least as the dermatologist, not to try to check hormones, in part because I don't know how to interpret them as well. Like, we don't know what the right amount of, FSH is. And so, outside of the constellation of other symptoms going on for that woman,
Right.
there's not a lot that I would do. That being said, there are several things that we do for hair loss that are sort of hormone adjacent, if you will, right?
Mhm.
So in some women, using something like spironolactone, which can help with binding up free circulating testosterone and can thicken hair. Can be really pretty low risk and can have an impact there. I find that I usually need to get it up a little higher, so like 100 to 200 daily. And certainly, I think that can be helpful. Oral contraceptives, if it's appropriate for that woman, containing estrogen can be helpful. And I think these are very commonly used in perimenopause anyway. And things like, topical dutasteride or finasteride, at least in a, perimenopausal or a postmenopausal woman, those things are highly effective and can be used topically or even orally as well. So I don't find it necessary to check the hormones because there's a lot of hormonal based treatments that I'm going to deploy anyway as part of the care of this. And so I say, let's just not worry about, what it's going to come back with as a number, and let's just target what we know works. And so that's usually what we do. Couple caveats I have to mention. So, spironolactone is teratogenic. It can feminize a male fetus. So always do your counseling if you're starting that medication, that if a woman wants to become pregnant, she does need to stop that. And similarly for the 5-alpha reductase inhibitors, it would be very inappropriate to become pregnant on those medications. And so we always do a lot of contraceptive counseling there too.
Oh, that's great.
Are those treatments that they'd be on for how long?
So the unfortunate thing about this condition is that this is something that they would be on for life. Much like, and we also deploy obviously topical or oral minoxidil in this condition as well. Just like we talked about in the telogen effluvium. The difference here being that if you, were to stop that medication, you would regress back to whatever your presentation would have been had you never taken it. Some patients ask me, am I going to lose more hair than I would have lost if I embark on this and then decide to stop it later? And the answer to that is no. You would have landed wherever you would have landed had you not intervened in the middle. So we don't think that, stopping these medications promotes more hair loss. But certainly for the motivated patient, for somebody who is, as depressed as she sounds, as impacted as she sounds, I think these things are quite safe. So the low dose minoxidil, the spironolactone is probably a great place to start. And I would give that again, like that 6 months, right? That 4 to 6 months to really see how you're doing, see if it's working. And then if they wanted to add a 5-alpha reductase inhibitor, either topically or orally in her, she's, I think, postmenopausal, right? That would be a very reasonable conversation to have. The other thing that I think we don't talk about enough, but I think should be on the menu of things that people can choose to do is hair transplantation. So for androgenic alopecia, for the motivated patient, hair transplantation is appropriate. You need to go to somebody who knows what they're doing. If you have an ethnic textured coily curly hair type, it is more complicated but not impossible. And they basically take follicular units from the occipital area that tend to not be hormonally impacted, and they transplant them up. Most of the hair transplant experts in the US will tell you they're going to prime the pump anyway by doing the minoxidil, maybe the topical 5-alpha reductase, maybe the spironolactone. So I don't necessarily say that you're going to get out of taking all medications by doing that. But certainly, I think for the right patient who is motivated to do the one thing that's really going to be more of a permanent fix, hair transplantation referral is appropriate.
Yeah, I mean, I'm a believer, Paul. I don't know about you, but like there's so many Hollywood stars that have more hair like now than they did like 20 years ago that it's like, there's some people out there doing decent work.
I wonder, is this the time to transition into TikTok therapies? Because I feel like all I know about hair transplantation are videos of people going to Turkey, because I guess it may be prohibitively expensive here. I'm not really like, it sounds like it's cheaper for some, in some cases, to get an airplane ticket and fly out of country to a specialist, and then they come back and document their journey. There's a lot of hair stuff on TikTok. So can we do some quick hits in terms of things that I've heard are sort of popular treatments? Are you okay with?
I love it. Let's do it.
Hit me. Let's do it. There are so many things that people try.
I heard, and maybe it's, maybe it knows that I pause, and so it's been feeding me these things. Maybe this is my own algorithm telling on me, but I saw...
they heard your hat story, Paul.
And yeah, exactly. Ever since then, I just sort of, maybe I should pay a little bit more attention. But even for genetic alopecia, topical ketoconazole shampoo is supposed to be like the big secret sort of hair growth. What are the thoughts on that? Is there evidence to support that or not?
So hair is a finicky crop, right? And subclinical seborrheic dermatitis is a thing. So maybe you're not like snowing a ton of dandruff everywhere, but you've got scalp inflammation. I think it's reasonable to use ketoconazole shampoo or, some of the zinc-based shampoos or cycloperox shampoo, whatever, pick your poison. But I usually just do the ketoconazole 2%. Sure, not gonna hurt. If you have a little bit of subclinical seborrheic dermatitis, it might help.
What about peppermint oil? Or I think rosemary oil is another one that I saw. I feel like someone cites like a research study of like 12 patients of anecdotal evidence, and like it works just as well as minoxidil. And I'm like, I don't think that's probably true. But what is
So
from a
there
professional?
is an essential oil that was studied in alopecia areata specifically. And it did have some promising results. I don't think it's been studied or shown to be effective in like telogen effluvium or androgenetic alopecia, right? Female pattern or male pattern balding. It is also, for many patients, tea tree oil, for example,
Yeah.
wildly contact sensitizing. And again, scalp inflammation, no matter what promotes it, whether it be psoriasis, contact sensitization, allergy, it's going to make it hard to grow hair if your scalp is inflamed. So I don't tend to recommend those things. People love tea tree oil because it's antimicrobial to some degree,
Mhm.
but it's also so disruptive to the skin's microbiome that I just feel that there's other ways to get to that end. And so I don't recommend it.
And then last ones, and then I'll stop, Matt. I'm sorry, you must be dying inside. But what about I see some medieval torture devices too, where people are like, running like needles over top of their heads, or I guess there's all kinds of tools you can do to sort of beat your own scalp up into
Like
submission. Are there
Hellraiser?
any of it to support those things? What's that? Yes, you're not dissimilar, Matt. Yeah, there's lots of like these sort of rolling, like running a pizza cutter through your head. Like it just does not seem like it should work. But I guess
So
the idea is to get your scalp so excited it grows hair. I'm not really sure.
yeah, so there is some data for that.
Get out.
What you're describing is called microneedling of the scalp. um, and there is evidence that injury to the hair follicles and hair follicle bulb specifically, so quite deep, can actually promote the Wnt signaling pathway that recapitulates the growth of hairs. We do this in return of form and function in scar revision therapy after burns, after blast injuries. Um, and so it doesn't really matter how you injure the hair follicle. We can use CO2 laser, you can use microneedling, you can use, I don't know, there's like the roller, there's like the one that like
Yeah,
bam, bam, bams the needles into your head. You can do
like a
that.
meat tenderizer.
Caveat though, here's the thing, you will introduce bacteria into all these little you've made hundreds, maybe thousands of little microscopic holes. And so just I don't tell patients they can't do it. And most of the over-the-counter devices don't actually go deep enough to stimulate the hair follicle bulb. Because if you think about histopath, the hair follicle bulb is super deep. So when we're doing intralesional Kenalog injections or when we're trying to, do some of these CO2 or microneedling or platelet-rich plasma or any of these things that we do, we're actually sticking the needles quite deep in your scalp. So most of the home devices don't go deep enough. And then people reuse the tips, and you will get a wicked scalp cellulitis from that. And so it's really important that people reuse the tips, and the tips are pretty expensive. So that's my caveat when patients say, "Can I do this at home?" I'm like, well, I mean, I'm not going to tell you you can't, but please do it safely.
So don't reuse the tips, right?
Do not reuse the
Right.
tips.
Okay.
Yeah.
Yikes, Paul. Scalp cellulitis. I haven't treated one yet, but
I am so excited I asked about that. Thank you so much.
great
Let me
question,
talk
Paul.
about real quick because, like, I know that there'll be like an outrage if I don't talk about red light therapy for scalps.
Oh yeah.
Right? So, like, all these, like, glowing headbands that you see, for sale, and they're, like, hundreds of dollars. So it's, like, low-level LED light therapy. It's a red wavelength of light, and it's the scientific, uh, premise here is that this is photobiomodulation. Super trendy. There is some evidence that it could help. The LED density, the amount of, radiance and illuminance that you get from these in home devices is probably not strong enough. One of the things you'll notice if you look at this over the last 10 years is that they sort of started with scalps and headbands and combs and all these things. And then that trend kind of fell out of favor. And now they've moved to these like LED masks, which are
Yeah.
exactly the same wavelengths, right? Like you're seeing them all over TikTok. And now they're saying, oh, it promotes collagen and it, decreases fine lines and wrinkles and it does all these things. And I'm always giggling because I'm like, doesn't it also cause hair growth like on your face? And so, do with that what you will. There is a scientific premise here that is rooted in, some decent evidence, but the home devices really don't do everything that they promote. And so, if patients are really trying to do things with their money that have benefit, I tell them, these things are probably not going to help.
Matt, have you ever seen one of these things?
I
On
have
TikTok.
not. No, I'm just.
It looks like a horror movie. Like it is terrifying. Like it's just like the Michael Myers mask with like a glow behind it. It is incredible. You should do yourself a favor and look it up when you get a chance. It's great.
Yeah, audience, I'm not on social media, but now I'm, all these dumb trends that we're hearing about. No, sorry to people that, I don't mean dumb trends. I mean, all these just like trends we're hearing about. I'm kind of, now I'm kind of curious. Maybe I'll have to check this out, Paul. Maybe I'm getting back on social.
Well, and it does speak to the desperation that is here and how important sort of hair and appearance is to people. So I mean, to back to sort of original point, like
of course.
people are sort of desperate to try anything, and so no shame here, just curiosity.
The other
and
thing that you're going to get
fun.
asked about is exosomes and secretomes, right? Which are not FDA approved in the United States. They are injecting them in Asia. People here are microneedling and applying them topically. They're using them in creams, lotions, potions. Again, not FDA approved, not regulated in the United States. Probably coming forward in the next 5 to 10 years, but we're not ready for prime time yet, and they are wildly expensive. So again, something that I think is coming forward with the science and probably will become part of the arsenal, but is not there yet.
And I have heard people microneedling and then rubbing minoxidil in. It's just anything, you're just shoving it in, aren't you, really?
Yep. And that's actually, I mean, as long as they're keeping themselves safe, and they're not reusing the tips, everything's quite clean, go for it, I guess. You can't keep people from doing things at home. But I guess the hot take I would have for that, devil's advocate, would be if you're responding to topical minoxidil, even just topical without the microneedling, why not then switch to very low dose oral minoxidil in a tablet form, assuming your patient has the right, constellation of risk factors that would make that responsible and appropriate, and then just do it from the inside out. It's just easier.
So, Helena, I guess along those lines, let's say if we change this from Carrie's mom to Carrie's dad, who also has concerns about thinning hair, and I as we're sort of talking about social media and online stuff, I'm feeling I guess there's some online outfits that will actually prescribe medications through like quote unquote consultations. And so it's much easier, it seems, to get things like minoxidil or finasteride. And especially finasteride, I feel like I've heard more about. Can you tell me what the going thoughts are in terms of the alpha reductase inhibitors and sort of efficacy, side effects, indications, sort of things to look out for, just because they're so much more prevalent now. And I think sometimes even our patients get them without necessarily coming through us.
For sure. So, particularly for the 5-alpha reductase inhibitors, it became more common to use things like finasteride at like a milligram daily, or even dutasteride, which has a longer half-life. I think the study was done Monday through Friday at a half a milligram daily, 5 days of the week, so Monday through Friday. But one of the things that did come out of that is this idea that, there may be this irreversible erectile dysfunction that's associated with that. And the jury's out as to whether or not that is truly seen across the population. So a lot of dermatologists believe that there's a little bit of like a nocebo effect, right? So you counsel about it, and then patients are worried about it, and then it happens because they're thinking about it or they're worried about it. And so some of my gentleman dermatology colleagues will actually say, like, I take this medication. I have not noticed this problem. Let me know if it comes up for you. But, this many number of patients of mine are on this, and I have only had to stop it for, a minority of them. One of my hair transplant colleagues likes to make the analogy, we know that there's sexual dysfunction with like SSRI and SNRIs. we stop it, it gets better. It's far more common with those medications than with the 5-alpha reductase inhibitors. So she acknowledges that this happens, but she also sort of couches it as, she believes that it's reversible, and all of her patients have had, when it has come up rarely, it's been a reversible side effect for them. The thing that has come up in literature more commonly and much more recently is that finasteride, even at these low doses that we use, has been reliably and repeatedly shown to decrease seminal vesicle fluid and change sperm and semen viscosity. And there's about a 10% reduced sperm count. So most men, luckily, make far more sperm than they would need for their reproductive health needs. But for somebody who is known to have a low sperm count, or who is having fertility issues with their partner, I think avoiding these medications makes a lot of sense, at least during that period of time. The good news is that this does appear in most studies to be reversible within about 3 months of stopping the drug. And so just counseling patients like, hey, if you decide to conceive with your partner, you might want to, increase your likelihood of that happening by, stopping these medications about 3 months before you want to get pregnant.
The erectile dysfunction question is tricky because I feel like this is also a time where you're prescribing to someone who has risk factors independently for erectile dysfunction, who has like the vasculogenic and maybe some dyslipidemia, and they're approaching middle age. And, so like this might be someone who has some dysmetabolic stuff to begin with. Is
Mhm.
that, and this may not be the right form for this. Is that something that can be overcome with like the PDE5 inhibitors, or is this, when you say irreversible, just we're talking irreversible and game over?
It depends. I mean, I think that it tends to be. I have not personally had patients in whom it's been irreversible.
Gotcha.
So, that's been my prescribing experience. I do discuss it with patients. It's not even really necessarily in the older men. It's been described in young folks as well. There are like whole Reddit threads about this. So
Mhm.
definitely, it's a hot topic out there. And for the patient who's going to go to the internet and search for things, I always think it's better to sort of address these things in the clinic before they go to the internet and read all these things. But I just ask them to be really open with me and let me know. And certainly there's so many different things we can do for androgenic alopecia. The minoxidil is a great place to start, for example. So if they're very motivated to avoid these side effects and they're worried that it might happen to them, then certainly we can just dodge that by not using these at all. And that's fine too.
So we have oral or topical minoxidil. There are some of these online companies, and they'll say they're giving these preps with like they have topical finasteride and topical minoxidil. I thought I
Mhm.
read that topical finasteride is proven for women, but not necessarily for men. But are you using topical finasteride for any of your male patients?
Absolutely. I think some of
Okay.
the compounding pharmacies make a really convenient um, preparation that contains multiple of these. I think after the New York Times article came out talking about, low dose oral minoxidil and how many, thousands and thousands of patients were tolerating it. And after we've done more of a literature dive to see at these low doses, is it safe? Is it well tolerated? What's the difference between taking a very low dose orally versus absorbing it through the scalp at that body surface area? You do absorb it, right? So just because you're putting it on the surface of the scalp doesn't mean you're not, absorbing some of it. So there's some equivalency there between taking a very low dose, and I'm talking like 1.25 milligrams daily of oral minoxidil, and that can just replace having to like put like a grease or a foam in your hair, right? Which can be kind of hard for your hairstyling, kind of tough on your pillowcase, right? And so I think those things are becoming more common. I usually do a cardiac review of systems for these patients if they have any history of cardiac disease, or if they have hypotension or orthostasis. Then I definitely don't prescribe, because minoxidil is a pretty potent antihypertensive, right?
Yeah.
But for folks that are otherwise, healthy, don't have a cardiac history, then I think we are moving towards doing the tablets. I like to have patients use it topically first for at least 4 to 6 months, because you have about a third of patients who are just basically non-responders. And so I wanna make sure that they like it, that they tolerated it, that it's working for them, and then at that point, they wanna shift over to the tablet, we do that.
Mhm.
But yeah. And then, what was the other thing I was gonna say? Just escaped me.
While you're thinking of that, we see with patients on oral minoxidil, we see lower extremity edema because it's a
Yes.
vasodilator. We see rebound tachycardia, and that's usually they're getting 2.5 or 5 milligrams a day, and
Mhm.
it's often like sort of like a Hail Mary pass for a lot of times patients with advanced kidney disease that are like needing
Yeah.
something else for blood pressure. But as a general internist, I don't prescribe oral minoxidil that much. I mean, now you're talking about this for hair loss. I think in that low dose, 1.25 milligrams in a patient with no cardiac risk factors, I think I would be game if the patient was game.
Some of the patients, you jog my memory. It's very hilarious in these dermatology like listservs. People will take this and they will get like immediate puffy leg, even at very low doses. So it's like this idiosyncratic. People are like, "Wow, look at my ankle, my cankle. I can't even see my malleolus." And I think the thing that everyone's always afraid of is that risk of pericardial effusion, right?
Mhm.
Appears to be idiosyncratic, possibly in the literature happens more at higher doses. I think overall is exceedingly rare, but I do counsel people if you're becoming dyspneic on exertion, if you have a positional dyspnea, if your leg blows up and you can't get it in your clog or your shoe, then this is not the right medicine for you. But for the most part, it does appear to be pretty safe.
I think we have to move on to our just last scenario real quick. So, Kate, if you wanted to set this up for us.
Yep, sure. So Malik is a 45-year-old businessman who arrives at your office at Cashlack wearing a baseball cap. He takes his cap off and shows you large circles of patchy hair loss, which he tells you have been appearing in the last year. The appearance is a bit mixed. Some are shiny, some have a few hairs but are getting larger. His eyebrows and he has patches on his beard. They're disappearing. He has tried some herbal hair growth serum he saw on social media, some scalp stimulating shampoos that contain things like caffeine. Nothing's working, and he also has an area of skin on his arm that you've noticed that is actually depigmented. He's African American, and over the year he's had lots of different hairstyles with his kinky, coily hair texture and type. He's used various topical products as styling, and his hairline has receded because he's had some traction alopecia as well. So he's got a family history with his mother has hypothyroidism and rheumatoid arthritis, and he himself takes 100 micrograms daily of levothyroxine for hypothyroidism. So can you talk us through like a sort of the cultural elements of hair assessment?
Yeah, I am. This is very also typical patient that we might see in the clinic, right? So often there's multifactorial hair loss. And so it's not just one thing, right? There's an element of traction, there's a little bit of subderm. And then you mentioned that there's these basically allopathetic patches of complete baldness, basically. And so that is always quite abnormal and would make you think of things like alopecia areata or discoid lupus on the scalp. If we can pull up the slide number 17. So here is sort of your classic presentation. Obviously, this is not our patient's hair texture type or skin tone, but at least as an example of that very, very smooth, completely, when you feel a patch of alopecia areata, it feels completely smooth, devoid of any hairs there. And you'll see that in the center, there is preservation of those individual hair ostia, right? The little hole by which the hair would come out. You can see those little dots. If you had a dermatoscope, and you certainly do not need one, but if you had one, you could even see little yellow dots at those ostia, and that's a pretty typical sign for alopecia areata. And this tends to be very circular, expansile. Hair pull test here is probably positive. So we do a hair pull test in the clinic, and a release of greater than 6 hairs is considered positive. And so those are things you'd be thinking about. Which, in contrast to slide number 18, would be another type of sort of discoid or nummular hair loss. Here, this is discoid lupus erythematosus. And here you can see there's quite a bit of erythema, hyperpigmentation, and hypopigmentation. It still makes the same shape, but this is a scarring, non-reversible process. And so, you really want to sort of try to figure out pretty quickly what's going on with your patient, why they have this patchy hair loss, and figure out what kind of treatment you're going to get them to. With discoid lupus erythematosus, we tend to treat this pretty assertively because we know that, at least in these areas, those hair follicles are obliterated. Those ostia are gone, and there is probably going to be permanent loss of hair in these areas.
Yeah. So I mean, it's not often in primary care that people walk in with like scarring, inflamed hair loss, and maybe that's because those people just just know viscerally that they need to see a dermatologist, not
Mhm.
me. But I don't know, Paul, is that your experience as well?
Yeah, I don't think I've ever made the specific diagnosis in the office or even really seen it, I think.
Yeah.
Well,
So,
good, because it's no fun.
Yeah.
but
Yeah, no, it
alopecia, but
sounds bad, no good.
the alopecia areata, though, that
Mhm,
does come up. So
mhm.
how do you talk to patients about that, and like sort of where does your mind go to for treatment, and what do we have to look out for?
Yeah, without getting too far in the weeds, I think, a patch of alopecia areata that is maybe singular, small, can come and go, not necessarily even in the same location. I tell patients, this is your immune system that's otherwise normal, healthy, and strong, and it's just made a mistake. It's just for whatever reason decided that the hair follicles in that part of your body are the enemy. And if you biopsy this, you can see this really robust inflammatory infiltrate. It looks like a swarm of bees actually down there around the hair follicle bulb. And your hair just gives up the ghost. It's like, I'm out of here. I can't grow in this. And so, that's really what this is. And so we really need to redirect the immune system away from that area. And there's like 100 ways to do that. There's so many good different treatments for alopecia areata. Something as simple as a very ultra potent topical steroid like clobetasol ointment under occlusion or applied twice a day might be a good place to start. If it's a place that's well hidden and the patient can comply with that, that's certainly something to do. I think somebody had asked me recently about the topical JAK inhibitors that have come on the market. Unfortunately, those are working better for vitiligo than they are for alopecia
Mm.
areata, but there are now some FDA indications for oral JAK inhibitors for alopecia areata. I don't know that I would jump to those medications for like a solitary patch. Um, I think topical therapy is always a great place to start. If there's multiple patches or if one's resolving while another one is starting to come on, if there's what we call an ophiasis pattern, so kind of an occipital expansile absence of hair growth, that can really be quite aggressive and progressive. And so those are patients I would definitely try to get into dermatology sooner rather than later. For patients who are I actually had a patient show up in the emergency room for just an explosive alopecia universalis. Like her hair was just coming out. I mean, it was pretty unbelievable, actually. And so, if that were the case with your patient, I think giving them systemic steroids and trying to get them into your local dermatologist as soon as possible would be a reasonable thing to do because it can be extraordinarily distressing. The number one thing that patients ask me about this is, am I going to go completely bald? Or once we get it to start growing back and it all fills back in, is it going to happen to me again? And the hard truth and the reality of this is that I have to tell them I don't know. For some patients, they'll have one patch one time, it'll get better and stay gone forever. And for other patients, they'll have recurrent patches, maybe one here and then, remission for years and then another one that we can sort of handle as they come. And then for other patients, unfortunately, it does become progressive and result in quite a bit of hair loss, and it can be much more complicated to treat. So, of course, you would refer those patients.
And I think the other thing is that patients are really motivated to do something as soon as possible to stop ongoing hair loss. So if we were prescribing in primary care, do you think we should just get them started on a topical steroid ointment or gel before they've seen a dermatologist, or does
Absolutely.
that's not going to interfere with any diagnostic process like biopsies or anything?
No, not at all. Yeah, that's a very kind and compassionate thing to do.
Yeah. Okay. Well, we've talked about so much, but I think we have to let you go. So can I ask you for a few take-home points? We talked about hair, a little bit of nails, but hair's the one we had a lot of these questions about. Paul had all his TikTok questions, which I enjoyed. So what are your take-home points?
My take-home points. So just remember that culturally, hair can be really important and quite a sensitive topic. And, patients are often ashamed or tearful or concerned about bringing up their concerns about hair loss, and really meeting patients where they are, matching their language, sensitivity, and how you do that exam, I think, can go a long way. Understanding and reading a little bit about ethnic and textured hair types that might be different from your own is a really good practice. There's no way to lose patients' faith faster than to tell someone, with an ethnic textured hair type to wash their hair every day. That's really inappropriate, and they're going to lose a lot of faith in you pretty quickly. And so I think it behooves us all to understand a little bit about those practices and what's appropriate. It's okay to ask patients, what types of medications they want to use, whether that be a foam or a grease, which would be like an ointment, or a solution on their scalp. Everyone knows kind of their own hair and scalp the best. Common things are common. So seborrheic dermatitis, certainly very common. Telogen effluvium, very common. But some of the other things we talked about today may be less common, and referring when you need to a dermatologist who can help with those things is very appropriate. And then finally, people spend a lot of emotional energy on their hair, and they spend a lot of financial money, right? A lot of financial energy on some of these products. And so meeting them where they are and not belittling them for that, but also routing them to the things that we know are evidence-based and rooted in good science, I think is a really nice thing to do for your patient, without kind of closing the door on them. And so, helping them navigate TikTok and deciding what to do that's best and healthy for them is the way to go.
So other than TikTok for all their hair tips, what else would you like to promote or plug, if anything?
Yeah, I think there are some really wonderful textbooks which we can I'll tag in the show notes for those folks who feel like they'd like to know more about appropriate hair care practices for different hair types. I think just having that to thumb through or checking that out from your local library is really a good place to start. And we didn't talk a lot today about things like cicatricial alopecia, and some of the things that happen more commonly, permanent hair loss of an inflammatory nature. But sort of just reading about those types of things on places like DermNet NZ would be a good place to start, just so you can kind of train your eye. I do not promote that you need a dermatoscope. I do not promote that you need any kind of fancy special tools or cameras. I really think that, bringing your humanity to the patient who's concerned about these kinds of things and being comprehensive and holistic really goes a long way. And then patience. Remember that nothing in hair loss is fast, and really doing that trick of, circling the 4-week date on the calendar and visualizing with them that we're not going to change anything. And in fact, we're probably not going to see anything getting better until that date. So I'll see you back in 6 months. And that's not abandonment. That's just kind of what it takes to get us on the right track.
I love it.
This has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole. All right, world was your oyster, and you chose not to eat oysters. Still hungry for more? Join our Patreon and get all our episodes ad-free, plus twice monthly bonus episodes at patreon.com/curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. This includes our Curbsiders Digest, which recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value practice-changing knowledge, and we want your feedback, so email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME through VCU Health at curbsiders.vcuhealth.org. A special thanks to our writer and producer for this episode, Dr. Kate Grant, and to our whole Curbsiders team. Our technical production is done by Podpaste. Elizabeth Proto runs our social media. Jen Watto does our Patreon. Chris the Chew Manchu moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
I've been Kate Grant.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.